Thank you for sharing your valuable time and safe travels.
Thank you so much.
Now.
Take care. Take care. I'll be in Cambridge tomorrow at the Global Neuro meeting. So
great.
Take care.
Lily is there as well.
Take care. Very good. Take care then. Bye-bye. Bye-bye.
Okay, so I think now what we have as a next speaker line is Professor Ruli Dahlian from Indonesia. Ruli, are you there?
Yeah, Nick, I'm here. Hi, Ed. Hi, everybody.
Hello, hi, Ruli.
Hello.
Please share your
Okay, I
talk.
will share my screen.
Nikolai, when am I talking? This is Ed Benzel.
If you want to, so I'm sure if you are ready to go now, Ruli will be happy to get you ahead, or you can talk after him in 15 minutes.
I'll talk after Ruli. He's ready. He's up. Ruli,
Perfect.
take it
Great.
away.
Okay, I'm ready, Ed. Yeah, okay, Nikolai. I will. Actually, it's quite easy for me because Professor Fellings already described many things about the spinal cord injury. My topic would be about management of cervical spine trauma this tonight, and I'm happy to see you all, and it will be grateful to be with you at this moment. Wait a minute. Yeah. In our country, just like in India and China, and you can see this is how it's happened every day, and 5 to 6% in a bike, and it will lead to so many trauma case in our country, and especially at this time we will talk about spinal cord injury, cervical spine injury. Cervical spine injury is an injury that related to spinal cord and all of the structure within it. And it's not about the spinal cord only, but it's about all the structure, the bone, the ligament, the joint, and everything. And we need to describe that avoidance is act of keeping away, of withdrawing from something undesirable, preventing from happening. This statement is needed to manage a cervical spine injury. And complication is something undesirable happen that makes situation difficult. So complication would come if we mismanage or we are delayed to do management of a cervical fracture. And the error is preventable even that should not happen, but it happened anyway and harm the patient. Spinal cord injury is a traumatic and non-traumatic and acute and chronic event, but in this presentation, I will talk about acute cervical spine injury. 50% of trauma are from motor vehicle accident, falls, work, fall down from building, crime, and sport-related injuries such as gym and stuff like that. And 56% it happened on cervical spine. It's very high because cervical is a mobile, very mobile structure of all the spine level. And the ratio was 4 compared to 1 for to male. And it's makes sense because a male is exposed to the work and sport, danger sport. The principle of definitive treatment is first to realign the spine, second to preserve the function of neurologies, minimize stress of compression, stabilize the spine, do rehabilitate, and obtain a functional recovery. And we need to know where we're standing when we face the spinal cord injury. There's so many types of spinal cord injury in cervical. It could be come as a central cord syndrome, facet dislocation, both unilateral and bilaterally, cervical burst fracture, spondyloptosis or spondylolisthesis, cervical fracture in hyperostosis, fracture in undiagnosed ankylosing spondylitis before, craniocervical injury of the spinal, rotational injury, and cervical spatial fracture. We know that there's some type, a type of cervical spatial fracture that I will not talk much about this in this presentation. And this is the Harris classification: rotational injury of C1, C2, fracture of C1, and odontoid fracture, lateral mesh and pars fracture. And then we can see there's a lot of fracture of cervical, a lot of type. And what is the most concern is in cervical region, every level had its own specific treatment. But the most important is timing is very important in cervical, because the more we delay the management, the more the translation and all the structure will become permanent. We know that there's a radiologic assessment like plain radiograph, CT scan, MRI, and angiography, and all of this we can do with spatial purpose, with some kind of trauma. You can see there's a fracture, a burst fracture, spondylolisthesis, spondyloptosis, burst fracture, and so on. And sometimes we can do angiography to find the injury of the vertebra or the translation of movement of the vertebra due to fracture of cervical. And then MRI is needed if we need to find a contusion. So if I suggest if we can find the fracture from the X-ray and it's show the malalignment, we can just do the surgery without MRI in our country, because too long to wait for MRI. We just do MRI if we suspect any contusion in cervical and there is no fracture in the CT or plain radiograph. And we have so many choice of stabilization. We can put anterior plating, we can put 360-degree surgery, or we can do posterior approach and do the compression, or maybe we can fix the occipital cervical junction. And this is some kind of another surgery that somehow in C1, C2 fracture, we can put the C1, C2 plate transorally to reduce the fracture of the odontoid and to realignment C1, C2 subluxation. And very important is the cervical fracture is most devastating. It's life-changing for the patient, lifelong constraint and limitation, and it's like a death sentence. So that's why we need to very careful in dealing spine cervical fracture. Pneumonia 34%, pressure ulcer 33%, deep vein thrombosis 15%, emboli and others less than 6-7%. And this is another complication that happened in cervical spinal cord injury after mismanagement. And we can see this is the, this is the table of the complication. It's not important. And we need to do the avoidance, because the cervical is a system that very mobile and it contain ligament and everything. So when it's happen, cervical spinal cord injury, it will disrupt the vascular structure. This is the most important. So in my this presentation, I want to put a stress to that. Not decompression is not just done for the spinal cord itself, but it's very important, more important to do the decompression to the vascular structure. We can see this is some syndrome due to the vascular structure injury, and the essence is primary. It's happened when the cervical spinal cord injury happened, but the secondary is very damaged. It's very progressive, and it's always continue after the cessation of primary injury, and it can be worse in the next 24 to 72 hours. Like Professor Felling said, that early management is very, very important. We can see this primary injury, it's happened at the moment of the injury. It's just contusion, shear, compression, laceration, and stretch. But the secondary injury like vasospasm, ischemic, excitotoxicity, mitochondrial dysfunction, and everything biomolecularly will damage the spinal cord, and it's give a non-permanent damage. Then and the secondary damage zone will getting wider and wider and wider, and it will damage all the spinal cord at that level, below and above. And we can see this in spinal cord injury. Cervical, we have immediate acute phase, subacute, intermediate, and chronic phase. And we can see that less than 48 hours is very, very important to do the decompression of the surgery. And there's I will show some journal even after this. And this is the window period of the cervical spine injury. We can see at the first day one is recommended for surgery, and the hyperinflammation is after 1 day to 5 days. We can do surgery, but we have to look the what it happened in this spinal cord itself. But after 10 days, we can see there is no surgery timing that we need to evaluate, because the surgery in after 10 days most of the time will not help the patient. So I would suggest before 72 hours we can do early surgery. This is a journal about surgical decompression and acute spinal cord injury. And this is another journal. I think we can find so many journals comparing about timing of the surgery, including the our spine recommendation. And in this moment, I would like to invite all of you to the World Spine 10 in Bandung, because World Spinal Column Society with Indonesia Neurospine Society is joining, managing International World Spine Meeting in Bandung, the city of mountain. And if you interest to come, it will be great moment for friendship and academic session. It will be this year in December, 10 to 17 December. And as a conclusion is in cervical spine management, we must do avoidance at earliest to prevent complication. The first 48 hours is your golden time, but the first 8 hours had the highest value. Most of the time, if we done the surgery, I haven't published our research yet, but if we done surgery for the first 8 hours, the pledgic it become motoric score 4. So it's very important to do the surgery in the first 8 hours. Cervical traction is very important in selected case, but it's only temporary while await for the surgical preparation. And tracheostomy in the first 12 hours is very significantly decrease the rate of morbidity of the patient. Thank you very much, Nikolai and everybody, friends. I hope, thank you for listening.
Thank you so much, Ruli. It was great presentation, and it's great to have you today. And thank you for sharing your time with us. And I